Thank you and welcome everyone to the Empowering Dosimetrists with Advanced Image Registration Tools webinar. Good afternoon to the people on the East Coast and good morning still to the attendees on the West Coast. My name is Holloway. I'm a product manager and also aid with clinical applications for Velocity. My colleague who will present the second half of the presentation, which will involve showing some clinical cases shown in Velocity, Yvette Bellingen, is the Director of Clinical Development. And just a note that many of the slides that you're about to see are provided courtesy of Eddie Schriedman from Emory University. Okay, this here today with this webinar is to hopefully present educational information about deformable registration in radiation oncology. And we have observed that image registration of any kind, whether it's rigid or deformable, is often required of dosimetry. So whether you're simply interested in learning more about deformable registration or are currently shopping around for deformable registration software, or perhaps you already have deformable registration, the registration QA was a really hot topic at both AAMD this year and AAPM. So the timing is really to show off like the latest in Velocity's deformable registration assessment tools that also usually correspond to assessment tools in other commercial products as well. So through this presentation, we're hoping to identify the different types of rigid and deformable image registrations, how to assess those deformable registrations using QA, and then how to review some of those applications of deformable using real clinical cases. The question is, why deformable? Actually, in this slide, these are all 3D images of the same patient. And, I mean, it really comes down to anatomy changes. Patient's body position changes in different table setups. Weight loss occurs. Tumors shrink and grow. Anatomy can even change in a matter of seconds, like particularly in the pelvic region. So, like here, you see all these images with sometimes the patient's arms are up, sometimes down. In the PET-CT, their head's tilted forward. So there are just too many scenarios in the radiation oncology field where rigid registration is limited. So basics, let's start with the rigid registration. This slide helps illustrate the degrees of freedom that you currently may have to work with within your treatment planning system. So you've got the typical 6 degrees of freedom where you can move the entire image up, down, left, right, and then also rotate it. But again, as you can see in this example, the rigid registration is limited in that we struggle to align this patient's anatomy due to the change in neck bend between the 2 scans. A deformable algorithm. Well, again, this picture kind of shows you, a rigid registration is really treating the image like a brick. Again, you can rotate it, translate it, but you can't bend a brick, and it doesn't allow you to bend the body. But we all know that the body moves, and so deformable would allow you to move all of those individual voxels. But that's much more complex. Even a rigid registration can be difficult to place by hand or using visual inspection. So can you imagine the difficulty in manually adjusting a deformable registration and moving all the individual voxels by hand? So therefore, we use algorithms to mathematically process and deform all those image voxels for us. And care about the deformable algorithm. Well, first thing that you should know is there are different types of deformable algorithms. And we're about to go through a couple of those different types. Different commercial products may offer a different algorithm. But the trick is that with each of these algorithms, not only is it trying to solve the math problem of matching up the image to each other, but the trick is that you also want to make sure that it's done in an anatomically correct way. The more educated you are about your deformable, the more you might realize the restrictions of the particular algorithm that you're using and which cases that you may or may not want to apply it to. Deformable registration kind of breaks down into the recipe shown on to the left. There's really 3 main ingredients: the transform, the cost function, and the optimizer. And the main 2 that I'm really going to focus on is the transform and the cost function. So let's make our picture a little bit bigger here. We've got our source image that we want to make it match to the target image. So we start off with those two. Anytime you do an automatic registration, you start off by taking a measurement, and you optimize it. So that's the cost function. How similar are those two images? Then you go through, apply a slight transformation, and then come back and compare how did the transformation, moving the source image, affect the target image. So again, now we match those two again after the first movement, and then we take a, and then we decide, is this measurement better or worse than the previous one? And then it keeps going in that iterative process where you take a measurement, move it a little bit, and then come back and compare. Move it, and then transform it, and then compare. And so all of this is to get down to a baseline movement until it basically says these two images are as good as they can get, and then the transformation stops. So we have an example where we have the cone beam CT as our target image, and the CT image in the bottom right is your moving image. And you can see that there's rotation of the image needed, and also that the bladder and the rectum have been deformed between the two scans, or they're in different positions. So let's first, the rigid part of the registration. Now, a function that we're going to show will be to minimize the Hounsfield differences, right? So we'll assume that if bone is, of high value, if it's lined up with bone, then subtracting bone from bone should zero out. So if all the tissues are matching and they're on top of each other, that's when it's all zeroed out, and the Hounsfield unit differences are minimized. And then again, for rotation, our transform will be just translation and rotation only at this point. Okay, for animation, we're first doing the translation as that image is coming down, and then it kind of settles into place. It ends with doing that rotation at the very end. So that's what the automatic rigid is doing. In the lower right-hand corner, you can actually see the cost function that the algorithm sees. So it's trying to maximize the black. As the black overlays, that means that those Hounsfield units are canceling out. So the more black that you have, the better the registration. So that's what the algorithm sees. So in a rigid registration, we can see like where the green arrow is pointing, but there was a good matchup of that bony anatomy, but there are a couple areas where the red is pointing to that a rigid really can't get those areas completely aligned. And it kind of makes sense that it's the soft tissue. So this patient's body outline, and also where the rectum is where the changes are that we don't have a perfect matching. So we really need to use Deformable for that soft tissue. Okay, next we're about to start the Deformable, and the only difference in this example between the two is the transformation component. The cost function is still the same. We're still trying to minimize the Hounsfield units, but now increasing the degrees of freedom and the complexity by using the transform of a Deformable to move each of those individual points around. As animation begins, you'll see that the planning CT is going to wobble and move a little bit to better fit along to the cone beam CT. So as it moves, again in the lower right corner, you can see that cost function trying to maximize the black. And this is just on repeat. So if you see it go back to the white, you can see that that's the initial starting spot. And then as it deforms, we get more and more black. So that's when the algorithm stops, is when it has the most black that it can. Okay, like I was saying, there's different algorithms. Now you just saw one example where the cost function was intensity-based. What we're doing with an intensity-based cost function is assuming that a voxel in one scan has the same intensity in the other scan. So, here we're hoping the heart tissue is the same intensity as the heart tissue in the other scan, lung to lung and bone to bone. So that can work really where your scan is, the same person and the same modality. But you can imagine that there may be situations where you do want to do a registration that intensity-based would not be able to solve. And that's generally where mutual information comes into play as the cost function. Now, mutual information doesn't really care what the specific value is. So like here, maybe you can see those cross bars. In the CT scan, the bone is white, and then in the MRI scan on the right, the bone is black. And that does not matter so much to mutual information. It matters what anatomical features are present. So as long as we have the group of bony voxels in the CT scan, they can match to a similar group of bony voxels in the MRI scan. So mutual information is known for being a little bit more flexible. That takes me to polling question number 1. I'm curious to see what is an example where deformable fusion based on intensity matching might give poor results. And first I'll go ahead, I'll read off these answers, and then I'll launch the polling question, and you'll have 10 seconds to answer. So the first A, we have fusing external beam planning CT to brachytherapy planning CT. B, the pre-treatment thorax CT to a post-treatment thorax CT that has fibrotic scarring. C, fusing CT with bolus to a CT without bolus. Or D, all of the above. So let me get my question ready, and I'll launch that now. And you now have 10 seconds to respond before I close the poll. Okay, closing the poll now. Interesting results. We had about 20% for answer B and about 60% for all of the above. And actually, all of the above is the correct answer. Each of these are examples where you have a feature that is present in one scan that may not be present in the other scan. So matching intensity might have a problem with trying to match those things where one exists in one scan and does not have the matching intensity in the other scan. All right, so far we've covered the first part, which is the cost function. Now let's go more into the transform piece of the registration. There are generally 3 types of deformable registrations. I mean, here it can even break down further, but they really boil down to these 3. First, you have line, which is deformable based on a grid of nodes, and I have a slide coming up to show you an illustration of that. I also have a slide to show you how the Demons works on mass density gradient patterns using partial differential equations. The only one slide on is finite element models. Most commercial products at this point don't yet incorporate FEM. That one, it models organ displacements using physical equations. So you would assign a value, like a stiffness value, to each organ. So for example, like the bone, that would be a very, very stiff organ, and the bladder would not be a very stiff organ. But you'd have to assign these properties to each structure. And I think at this point there's a way of doing it, but you may have to actually contour each structure. So you'd have to contour the bone and then assign that a value. So from a speed standpoint and being able to do the deformable quickly, finite element modeling is usually slower. So most commercial products either go with spline or Demons. Okay, animation does show, kind of illustrates what's happening with the B-spline. This is not exactly what our B-spline does, but what you do is you have these grid lines across the image, and if you drag one node, then see how all of the voxels kind of smoothly go along with it together. So that helps keep the continuity of the image intact, and usually the B-spline has constraints that do not allow those grid lines to cross over each other. So this is a fairly good way of interpreting how the body moves. The D works matching intensity patterns, and it's usually more of a free-form type of deformable. And just to illustrate this again, I'm kind of going back to pictures. But if you can see in this picture that there's a nice gradient between the skin and the hairline here. And there's like 3 or 4, there's a few gradients there where the values drop off sharp. So what the algorithm sees in a Demons is usually something like this, where you see those sharp outlines. And then you can take an outline from one scan and try to match it to like this similar, borderline in another. So like, the contrast between lung and liver or lung and the rib cage provides that nice outside edge. Let's talk about the different deformable algorithms. Now, how does that apply to you and what can be deformed? In the most common clinical cases that I see are normally deforming a PET-CT, diagnostic CT, MRI, structure sets from one scan to another, doses can be deformed, and cone beam CTs can be deformed. All right, so that brings me into my next question, polling question number 2. When trying to deform a PET-CT to a planning CT, what technique would you use? A, deform the CT from the PET-CT to the planning CT, and then apply the registration to the PET. B, the PET-CT unfused image, so just deform the PET-CT to the planning CT all at the same time. I mean, it's just one image. C, deform the PET directly to the planning CT. Or D, none of the above. One should not attempt to deform the PET. So let me get my question ready. And I'll launch that now. Have 10 seconds to answer the poll. On the poll, and we have 54% say A and 28% say B. And it is maybe a little, I mean, at least you're on the right track. B can be confusing because it does seem like the PET-CT is one fused image, but really most of the time what we work with in the image registration is A. That would be the right answer because the PET-CT is in the segment planning position, and when you do the deformable, we can take the portion of the PET-CT that has more anatomical information, that would usually be the CT. So we fuse that to the planning CT and then simply apply that same registration onto the PET image. A case example of doing a PET-CT registration. On the left-hand side, we have the PET-CT for a patient, and the right-hand side is their planning CT. If we see rigid overlay of the two, we can see that we have a good high correlation of the skull and like the vertebral bodies. Spinal cord looks pretty well aligned. But there is some difference in the mandible, like where the nose is a little higher in one scan and the lower mandible is lower in the other scan. So that's the part that we'll try to see if we can fix that up with deformable registration. All right, next slide shows us the results of 2 different deformable algorithms applied to that image fusion. And I think visually you can see that there is some difference between the two, the B-spline on the left and a Demons algorithm shown on the right. And I am kind of curious, as in your opinion, which of these 2 deformables do you think is the better deformation, A for B-spline or B for Demons? So I'm going to launch that polling question starting now. And give you 10 seconds to answer. Okay, and we have 75% that say B-spline and 25% that say Demons. And, this is why this is a great question because, really it kind of could go either way. I guess I would maybe lean towards the B-spline, but it's hard to say because visually they both look very, pretty good for the most part. But where you can read the difference is once you show the warp map. And the warp reveals to you where did that deformable algorithm move those voxels to. So again, on the left-hand side, we've got the B-spline. It looks like the lower mandible, all those voxels moved down. The top of the head kind of moved upward. On the Demons, there are definitely some interesting results in this particular algorithm that we're showing. We have the brain voxels that seem to be splitting apart. So anatomically, we know that that doesn't happen. And maybe what's freaking is the area kind of in the back of the oral cavity, like the back of the throat, that there are voxels moving down there, even though it was not that far from the rigid starting place. So just let's quickly go back to our original picture to examine, what could be the cause of this. And if anybody paid attention, when I first showed this case, you may have noticed that in the mandible on the PET CT, the mouth was closed. And the mandible in the planning CT, the mouth is open. So this is a really tricky situation, and that can come across, but could be really difficult for Deformable to solve, because Deformable is more about moving the voxels around, either bending them or changing the size, but we can't insert air. We can't open the mouth and then insert some air voxels in there. So that's why it's nice to be able to see how did that algorithm respond to that particularly tricky problem. And so if you go back, if we go back to the placement map, we can see, the B-spline, it looks like, the lower mandible came down and the upper mandible came up. So probably what you are going to get is a stretching of the teeth voxels across that space. And the demon in this example is intensity-based, so it really wanted to match air to air. So when it didn't have any air in that space, it tried to borrow some from the nasal cavity and brought it into that area. And that, in turn, affected the voxels towards the back of the skin as well. So that's just nice to be able to see, analyze your Deformable. Not just the visual results, but also look at the maps to see, are your voxels moving in an anatomically correct way. By looking at how does that Deformable algorithm impact the PET registration. So you can see, depending on which algorithm I use and the results, whether one is more clinically valid than the other, can have a big impact on how that PET lights up once it's fused to that planning CT. So here you can see, again, the B-spline has a larger node, PET node still kind of in the same position on the left side. On the right side, that PET activity got pushed down because it's following that CT to CT registration. Okay, question 4. Is Deformable registration safe to use? A, yes, there is recent scientific research that validates Deformable for all scenarios. B, yes, but only in certain areas of the body. C, use your clinical judgment as to when Deformable registration is applicable. So I'll launch now and give another 10 seconds to vote. Okay, cool. And 91% answer C, which is the right answer. Deformable registration is a great tool, but you do want to use a clinical judgment as to when you use it, what cases you use it for, and analyze your results and see if they're even valid for using for your scan. Now, the take-home of this lecture, I'm not trying to scare you away from Deformable. Yes, Deformable registration is a great tool. It can be very useful for making treatment decisions and for efficient workflow, but do use your clinical judgment when you use your Deformable registration. And if possible, use whatever tools are available to you to assess the Deformable results before you continue on, because PET fusion structures and deforming dose are all dependent on how well that CT deformation is done. So we'll kick it off to Yvette, and she can show us some more clinical cases using Deformable registration.
Okay, everyone. We're just going to change presenters quickly. So, can everyone see my screen?
Yes.
Okay, so Sharon has explained the theory behind Deformable registration, and she's also identified the types of rigid and deformable registrations that are available in the radiation oncology field. We will now examine how to evaluate these deformable registrations and the importance of QA. So we will look at visual assessment overlay, the different ways we can do that. We will also look at the QA tools provided in the software by Velocity, and most of the vendors will have these tools as well. And then another tool which we're not going to discuss is if you've got a Deformable QA department, please do use that. So what I'm going to do is I'm going to go straight into the software, but I just want to quickly summarize how Velocity uses the concept of primary and secondary images. And given these two volumes, a primary volume and a secondary volume, we will always deform the secondary volume to match the primary volume. So if you think of Sharon's presentation and you look at the brick, that is the rigid, and the jello is the deformable, because we will mold the secondary volume to the primary volume. So how do we really do this? In very simple terms, we basically keep deforming the secondary volume until we find a deformation that best matches in the primary volume. So we can do this by evaluating how close the primary and the secondary volumes match after each iteration of the deformable registration process. Right, so think back to the deformable registration recipe. We've got the transformation, we've got the cost function.
Okay.
Yes.
Can I interrupt? I'm just seeing several comments that some people are having a hard time hearing.
Oh, okay.
Yep.
Can you? Is that?
It's still off, yeah, even worse.
Or
perhaps better, and it may help if you just speak up a little bit.
okay, almost if I was shouting. Can you hear me now? Is that better? About headphones quickly. Just hold on. I'm going to switch my earpiece.
Okay.
Can you hear me now?
That sounds to me.
All right. Okay. So if we go back to the deformable registration recipe, we've got the transformation, we've got the cost function metric, and we've got the optimization. So for each location in the primary volume, we identify its corresponding location in the secondary volume via the current deformation map that is applied. All right? So we use the primary volume as the coordinate system of interest. The primary volume becomes the center of our universe, so to speak, and else, whether we're deforming structures, secondary volumes, or dose, these are placed into the universe or the coordinate system of the primary volume. So when we speak of the grid, we are referring to a simple grid that is placed in a coordinate system of the primary volume. So what I'm going to do now, I'm going to go into the software, and I'm going to show you how we do a registration first. So what I'm going to do is I'm going to show the registration that Sharon did, the registration that she spoke of in her presentation, and I'm just going to run our little navigator that will quickly do this. So we have navigators that can do various options, and today we're going to focus on registering the CT sim with the PET CT. So as we spoke, we can't register the PET directly to the planning CT. We've got to take the attenuated CT that is linked to the PET with a DICOM registration, and we have to register that to the planning CT. Now the planning will be the primary volume, so that is the center of our universe. And once we've registered those through the deformable registration, we can just chain the PET to the planning CT. All right, so when I click, I can just go through the instructions that are given to me in the top left-hand corner. So I first select the images that I'm going to use. Once I've selected that, I click Next. I only have one PET, so the software knows that this is what it should use. And it also knows that there's a DICOM registration between the PET and the CTAC. So once I've got those up, I can now review the DICOM registration between the CTAC and the PET. And sometimes the patient moves between the CT part and the PET part. And in our software, we can correct for this. So once I've reviewed this and I'm happy, and I just want to show that this is the area of concern for us. So you will have in the department, you're going to have the pathology notes, you're going to have all the patient notes. Use them when you're doing a deformable registration, because that is the way you will check what is important. So what I'm going to do is I'm just going to change the contrast to my secondary. So my secondary image, if we go to the side-by-side view, my secondary image is the colored image. My primary image, as you can see, is the gray image. And if we look at this, and we just go through, you can see I've got a huge discrepancy in the patient position. So my PET CT has quite a bent neck, and my planning CT is in a nice neck straight position as we used to in oncology. So what I will just set my radiation. I will do a manual alignment. So Velocity does 3 different steps. We normally do a manual alignment. After the manual alignment, we apply the rigid registration, and once that is done, we will then apply the deformable registration. And you've got to just check in all planes you are well aligned. So you get it as best fit as possible. And if anyone at the double A&D presentations that John Pouliot and Mark Kessler did, you will see they also spoke about aligning your patients as well as possible in all 3, whether you're doing the rigid registration, the manual alignment, and then you let your deformable algorithm do all the rest. Now if you look here, you can see we can kind of get this right, but if you look at my nose position here, you can see I've got a big discrepancy. There's a big difference in position. And if you also look at the mandible, you can see there's quite a big area of discrepancy. So once I'm happy with this alignment, I go on to the next step, which is the rigid. Now for the rigid, the brick, it doesn't really, don't have to set a region of interest. But if I don't set it now, I know for sure I'm going to forget. So when you're happy in all 3 planes, and when you're happy, you then let the rigid registration pass. So what it does, it looks at your rotations and translations, and there's about 6 variables here. So it will align the spine pretty well, or the skull pretty well, but it's not going to really work and get my mandible or my nose into position, and nor is it going to get my spine into position. So once we've done the rigid registration, we can hand over to the deformable, and the deformable will then mold the spine and mold the mandible into place. All right? So this one, and then we can have a look. And the region of interest is dependent on what you want to do. If you're registering 2 images, and as I say, you will have the patient notes in front of you, so you're going to know the areas that are important and what you need to look at. I tend to set my region of interest a little bit bigger as opposed to smaller, because I can always cone down. The algorithm will allow you to continue with the next step of registration if you have completed this. What I do is I'm going to select the deformable multipass, and what it does, it runs the registration across 3 resolution grids. So it does a coarse resolution, a medium resolution, fine resolution. All right, and if I'm not satisfied with that, I can make my region of interest a little bit small and rerun the registration. Now this is completed, and if you have a look here, it has changed the PET registry onto the planning CT. So we now have the diagnostic PET registration that is chained onto my planning CT. All right? I cannot review this because I can't tell you how good the registration is by looking at the PET. So what I need is I need to go back and I need to select my CT part of the PET and then select my registration. All right, now if you look at this, you can see that's the deformable, and once again I'm just going to change the color so that you can see secondary is the yellow and the primary gray. Okay, and if you difference between the rigid registration and the deformable registration, you can see that this has, there's a big difference. So there's 3 ways. We spoke of visually, and it's always important. You have to know your anatomy. You can't do a registration without knowing the anatomy, and you've got to check everything. So you've got to do eyeglass overlay, which shows my secondary image in my bounding box, and I can make this smaller and bigger. So what I can do is if I just change this, and and you've got to review it in all planes. So if I look at this, I can scroll through my image and I can just check that my alignment of my tissue is correct. If I know where my nodes are, I can review them as well, and I can have a look, all right? So I'm all, and I can scroll through and change and have a look that everything matches. So that's the one way of doing it with the spyglass. We can also do what we call a blending. So you take your blending tool and you can blend from the primary. So that is my primary image. And I blend it to my secondary image, which is the yellow image. And as you can see here, we spoke about the air. The algorithm struggled to compensate for this. So you cannot put air where there isn't air. All right. So in the planning CT, this patient had a tongue depressor or a bite block, and in the CT, the mouth was closed. In the diagnostic imaging, the mouth was closed. So we can this way. Now, I've often seen the radiation oncologists, when we get on site, they like looking at soft tissue, and they like looking at a side-by-side view. And what you can do, if you place your cursor just on areas, and if you've got the anatomy and you know the pathology, you can review that as well and then have a look at these areas. So those are the visual tools. Now when you're done with the visual tools, we've got some really nice QA tools that the software, you have to review them all. You can't just rely on your QA tools. So what I'm going to do is I'm going to quickly show you the QA tools, and we enter into the registration panel here, and you can see we've got a variety of different tools. The first tool I'm going to show you is the direction vectors. So this will show you the way each voxel has moved in the deformation map. All right, so it shows you the motion. The size of the arrows do not matter right now because the arrows only show the direction in which these vectors are. So the colors of the vectors, they have a color. And if we look here, you can see we have a color scale that runs from yellow through to magenta pink. Yellow indicates the areas where we've had the most movement, and magenta indicates the areas where we've had the least movement. So the least movement would be in the area of the brain. I wouldn't expect much. I do expect motion where I had my nose as well as my mandible, and here in my shoulder area I would expect some motion. All right? So we can review that, and if we go to the one view panel, then we can just have a look at this and you can see, and we can scroll. I'm going to keep it on my sagittal because that's the best one that we could see the movement of the nose. So the yellow, remember, is the secondary, and the gray is the primary. We can also look at the displacement grid. Now the displacement grid, remember when we spoke about the B-spline defined on a grid of nodes, the optimization then finds the optimal nodal displacement. Now this grid is that lattice display that we've got. So if I put up my region of interest, you can see the red bounding box on the side. Inside that bounding box is where all my deformation took place. So this displays the grid, and the square boxes should keep their shape. Now the square boxes of the grid will get deformed based on both direction and magnitude of the deformation map at that location. So once again, we've got our yellow here that shows where we've had a good amount of movement, and the red will indicate no movement, and magenta will indicate minimal movement. So that's one way to view it. The other way to view it is to look at the direction vectors and the grid overlaid over each other. And if I just make this grid space a little bit bigger just to show you, you can now see each box represents a voxel, and the arrow indicates in which direction that vector moved. All right? Once we've got that, the other tool we've got is what we call displacement vectors. Now this shows both the direction as well as magnitude of the shift. And we've got another little tool here that is a little voxel curve tracking tool. And if you place it over, if you look in the bottom right-hand corner, you can see the value of the displacement. So this voxel moved in an direction, and it displaced by 16, more or less 16 millimeters. And I can move, if I move back to this little one, you can see that this displaced by around 6 millimeters. All right, so this is another way of viewing it. And once again, always view it in all the areas. Okay, so look in all the areas. Now I'm just going to quickly switch off the grid display to none. And we can view these images. I'm going to go back to this one. We can view the images either as a non-deformed secondary. So what that means is the secondary is still in its original position. So that's without the deformation map being applied. So it's in the non-deformed view. And if you then look at the direction vectors or the displacement vectors, you get a good idea where this tissue has moved. So you can see here in the neck, the yellow is the secondary, and this round neck here is the primary image. So that gives you a good display of where these vectors have moved. We can also view the deformed secondary, so that is the secondary position after the deformation map has been applied. The other way to view this is to look at the displacement magnitude. And what this is just a color wash in place of a secondary volume. And this shows you where you've had. So once again, if we look at our secondary color map, and I pull this in a little bit, you can see that in the yellow areas, which is the nose and mandible, is where I had my most movement. And here over the shoulder area as well, where once again the magenta shows the least or very little in movement. All right, so I'm going to go from here. This is now done the registration, and what I'm going to do is I'm going to go to the next patient, and I'm going to show you a recent recontouring patient. Now, this patient had treatment in August of 2008, and he came back in December 2008 with a recurrence. And if we look at this, I'm just going to show you here in the view. If we look at the pink is the secondary image, so this was the original treatment plan, because we will want to deform that CT to the new treatment planning position. And if we look at the new planning position, you can see this patient has shrunk quite a bit. This mass that we're seeing in the where my mouse cursor is has disappeared. So if we look at this and we go into the registration panel, you can see if I do a rigid registration, and once again, I'll change the secondary to yellow, and I'm going to check the best view to see here is in the box. So as you see here, you can see with the rigid registration, it's aligned bony anatomy, but it cannot compensate for the tissue loss that has taken place. So as you can see, this patient has shrunk from the first round of treatment to the second round of treatment. Now, if we go into the structures, and I did these earlier, I'm going to show you the parotid rigid. And if you look there, you can see that the parotid, when we've done a rigid registration, the parotid doesn't compensate for the change in tissue either. But if I put the deformable parotids, you can now see, and I'm going to go back and I'm going to do the deformable, and I'll toggle between these. So the dark blue is the parotid that has been pulled through the deformable registration, and the red parotid has been pulled through the deformable. The orange parotid on the right is the rigid, and on the left, the light blue parotid is the rigid registration. So you can see how the rigid doesn't compensate for this, but the deformable registration does. So if we now enter our registration QA and have a look, you can now see this areas, and I'm going to keep up there, and I'm going to zoom in on the parotid that you can see. So if you look at the back, the yellow might be a little faded, but if you look at that, you can see the direction that these vectors, these voxels have all moved. And if we go from this to the displacement vectors, and I'm just going to pull this out so you can see them, you can see the amount of movement that has taken place. And this corresponds to what we're actually seeing anatomically. So it's very good to review the images anatomically before you just go ahead and just look at the QA, because it's got to kind of all gel together and make sense. All right, so once again, the arrow colors show the most movement, and the pink shows this area of movement. And once again, if we place our cursors here and we pull in, you can see the amount of warping on the side. All right, so with these, and what I'm going to do now is I'm going to now show you just do the Jacobian. So I'm going to create the Jacobian. Now the Jacobian is very much the physicist's play toy, but what it does, it actually shows you the contraction or expansion of the structure. So if we look at this parotid, we know that this parotid has contracted. It's definitely shrunk, and I know by now that it has shrunk by about half. But prior to the webinar, and I just didn't have time to do this, I ran the deformable registration, and what I did is I created a report. So what you do is you take the deformable registration and you look at specific structures, like the parotid in this case, and I look at the amount of warping. So the warping is the amount of displacement that takes place. And if you see here, you can see that, and I'm just going to focus on the left parotid, you can see that the minimum amount of displacement was 4.89 millimeters. We had a maximum displacement of around 15.5, and we had a mean displacement of 8.53. So I know that this left parotid moved around 8.53 mean value. And what we then do is we then apply the Jacobian histogram. So we create the Jacobian and we have a look. And as I said, what the Jacobian does, it explains to you, it kind of just gives you the values, whether this structure has shrunk or it is expanded. I could see that the parotid has shrunk. So anything under 1 indicates that there's shrinkage. Anything over 1 shows that there's expansion. So if my parotid had shrunk by half, it would be a contraction of around 5. If it had doubled in size, it would be an expansion of around 2. So if we look at the region of interest here, and then we look at the left parotid, I can see I've got a minimum value of 0.21. The mean value is 0.55, and then I've got a value of 1.04. So where does that come from? If we go to this area and I scroll through the image, you can see in some places it almost looks, and over there, it looks as if the deformed parotid has actually expanded. So the Jacobian doesn't know where to expand. It can just give you the volume in 3D. Now, if we look at this value in the bottom lower corner, the 0.27 and the 1.98, that gives the size of the region of interest that we used. So if we look at the Jacobian, we had around 0.22. So let's keep it at 0.27. And then we went to about 1.04 was the maximum. And there we can see where the mouse cursor is now, we can see that there was a bit of expansion. But if I pull it back to the median value of around 5.5, it's giving me a color display of where I had my shrinkage and where most of this shrinkage occurred. All right? So from that point, that is how you can review your registrations and have a look and assess it. But as I say, there's difference. You've got to look at it both visually as well as using your tool. Now, just before we end off, I know we're probably close to this, I'm just going to show one more case how you can use this. So if you've done a dose summation, and if we look at this patient, and I'm just going to quickly show you, this patient had come back for treatment. He had an original lung treatment and then came back for head and neck. So this is the lung field. As you can see, and you can see here, it stretches over this. And if we look at the head and neck treatment, you can see we've got some over there. And if I go back to this and I do the composite of this, you can see we can add the doses and we can have a look at this. So there's various things we can look at. I would want to, probably if I was the physician, would want to look at the first dose. So I'm going to go back to my CT and I'm going to select my original lung dose. All right, I'm going to go back and select the registration. So there we can see over the tumor area the original. So this is the scarring because this is the new head and neck CT. So this is the patient coming back for treatment. And we can use this QA to have a look at like the direction vectors as well. So you can see in the dose summation how these voxels moved when they did the dose summation. Because remember, we speak of the primary as the center of the universe, and when we do the dose summation or when we do a deformable registration, we're rewriting this into the coordinate space of the primary. So if we look at our displacement vectors, we can then assess how much movement has taken place. All right, so we can see the amount of warping. And likewise, we can look at the sum doses as well with the QA. All right, so what now, we are done with the presentation. So if you have any questions, please don't hesitate to contact us. If you wanted to know more about deformable registration, you can contact support@velocitymedical.com, or you can call us on this number. You can ask for either Sharon or myself. Or if you wanted more about the product, you could contact sales@velocitymedical.com, or you can call us at this number. So on that note, I just want to thank everyone, and happy Dosimetrist Day. It's great to know that in this country they acknowledge the dosimetrists. I'm not sure how many other countries this happens in. So on that note, thank you very much, and if you've got any questions, we're available to answer.
Questions, feel free to write them in the chat boxes, and the ladies can answer them right now. If we get too far in, then they can answer them after the fact. I will give just one other reminder while everyone's waiting for questions to come in. If you are attending this live session as an individual, you do not have to worry about the quiz. If you're watching it as a group and you have any questions, please contact AAMD headquarters and I'll clarify anything. But if you are watching it in the group, only the person that was signed in will receive immediate credits. Everybody else will need to take the short 4-question quiz, which is available already online.
I think there's some questions coming in about the QA options. First question is, are they new to Velocity? There are some that are new in this version. The warp map we've had in all of our previous versions, I believe. And then another was, is the deformable registration and QA presented specific to Velocity software? That's a great question. There are a few different commercial products that do deformable Velocity party software, and there are others as well that do QA. Most of them, may have some tools or the others. Some have the point-to-point. Others may have the grid lines. So I guess depending on which deformable software you go with, that can determine which tools you have in the system.
A question, someone asking if this was available in 281. No, the warp map is available in 281, but in the newest release of Velocity, we've brought up a QA tool specific to do the QA of the registrations.
Two other really good questions coming in, guys. Is this type of treatment planning system in widespread use in the United States? And I would say yes. In the past, really 2 years, I've seen it taken off, with very rapidly with sites acquiring deformable image registration. So I think deformable image registration has been available like somewhere between 5 to 8 years, but it took, maybe a few years for the field to become comfortable with deformable registration. And so now we're at the point where a lot of sites are acquiring this technology, and that's why it is such a hot topic at AAPM and AAMD, is because they're concerned about the accuracy of the deformable, and can you deform dose? And they do have a task group with AAPM. It's task group 132, and they should be coming out soon with some recommendations of how to QA whatever deformable, product you might have or buy.
Pretty well wrapped up, ladies?
I think so.
Looks like it. All right.
I think so.
Well, thank you, everybody, for coming to our second webinar. We've got 3 more this week. You are welcome to attend all 3. There will be a short webinar survey that will go out as soon as you end your webinar. Please take the time. It'll take you 30 seconds to answer it. There's a bunch of yes or no questions. Trying to think anything else. Nope, you're welcome to, the rest of the webinars, we have plenty of seats. If you've got any of the colleagues that would like to participate, they are welcome to. Recordings will be available for a month, so if you do have colleagues that were not able to attend, they can watch it until September 20th, take our short quiz. As long as they have an AAMD account, member or non-member, they can watch the webinar, take the quiz, and be able to earn some credits. So we'll see everybody tomorrow. Thank you.
And AAMD is because they're concerned about the accuracy of the deformable and can you deform dose. And they do have a task group with AAPM. It's task group 132. And they should be coming out soon with some recommendations of how to QA whatever deformable product you might have or buy.
Pretty well wrapped up, ladies?
I think so.
Looks like it. All right.
I think so.
Well, thank you, everybody, for coming to our second webinar. We've got 3 more this week. You are welcome to attend all 3. There will be a short webinar survey that will go out as soon as you end your webinar. Please take the time. It'll take you 30 seconds to answer it. There's a bunch of yes or no questions. Trying to think anything else. Nope, you're welcome to, the rest of the webinars, we have plenty of seats. If you've got any of the colleagues that would like to participate, they are welcome to. Recordings will be available for a month, so if you do have colleagues that were not able to attend, they can watch it until September 20th, take our short quiz. As long as they have an AAMD account, member or non-member, they can watch the webinar, take the quiz, and be able to earn some credits. So we'll see everybody tomorrow. Thank you.